Now, the COVID-19 pandemic has provided an opportunity to test some of the mechanisms behind South Africa's proposed national health insurance system. The centralized nature of the ways in which procurement of vaccines is just one example in which that was done. To join us for more on this conversation and to discuss the lessons that we have learned from the COVID-19 response and how those link to the NHI, we're joined by the Health Justice Initiative spokesperson, Tinashe Njanji, and the Wits School of Governance's Social Security Systems Administration and Management Studies Chair, Professor Alex van der Heever. Good evening to both of you, and thank you so much for your time tonight. Professor van der Heever, let me begin with you. I suppose it's really about the different strains of what has been proposed in the NHI that we have seen being somewhat exercised under COVID-19. What are some of the big ones that jump out at you?
Well, I think it's revealed a lot of the problems with attempts at over-centralizing certain administrative functions. So the idea of centralizing the purchasing function of healthcare at a national level is highly inefficient for rendering services in any health system. So I think that you can centralize very simple decisions at a national level, but typically it's more appropriate for them to deal with resource allocation, how you allocate budgets, and maybe setting strategic norms and standards, but not to actually buy things. And I think that becomes incredibly difficult in a health system and lends itself to corruption, which is what we've also seen as well. And so we need a different governance framework for our health system and our universal coverage system, but I don't think that the centralized options along these lines are going to work very well.
Of course, a part of what COVID-19 has done is really highlight the need for a universal health insurance system.
We have to have a universal health system, a universal coverage, in that we ensure that everybody has access to health care. We are not necessarily going to be able to do that all with the government budget, and I think that is just something people have got to get used to. It's not going to happen any other way. A universal coverage model in all health systems around the world will involve both the government-financed portion and one in which people contribute so that they prepay for access to their health care. But you have to provide the stable institutional framework for that to happen, and you have to harmonize the systems between what would essentially be a contributory one where you pay a contribution for your coverage, and that where you effectively access free care. That together gives you universal coverage. But not everybody's going to be funded by general taxes. It's just not going to happen. But we do need an institutional framework that manages this effectively, and we don't have one. But we are therefore not in a good position to guarantee people's rights at this point.
Tinashe, let's talk about perhaps the similarities that you have seen and where it is that the ideas of the NHI have really been put into practice during this period.
Thanks, Ms. Kathy, and good evening to your viewers. Just a point of correction that I work for the People's Health Movement South Africa, and I'm the coordinator there. And work closely with Health Justice Initiative. So one of the statements that we launched, that's when I was a spokesperson of the joint event that we have. What we have seen, is that we need to acknowledge that basically understand that health is a fundamental human right, and therefore we need to treat it as a public good and not as a commodity. And also, we've seen that our country needs healing, and what we need, and that is going to come through an effective and well implemented NHI, where we're going to see the solidarity within those who are weak will be subsidized by those who are healthy. The young will be subsidizing the old, and so forth. Also, one thing that we need also to see within the NHI is that good health for everyone according to their needs, not according to their means. Also, we've seen that public health, if it is essentially controlled well and implemented well, things will work differently and better. We've seen that from the COVID-19, where we've seen a lot of activities, a lot of testing, a lot of vaccine happening within our public system.
Of course, one of the things that was quite interesting to watch was the public-private partnerships between, the hospitals that at a time of crisis when the public hospitals were overwhelmed or the private hospitals were overwhelmed, and they needed to be almost a sharing of the infrastructure for various patients. What are the lessons, Tinashe, that you think have come from that?
Yeah, one good lesson that we need to take from there is that one population, one health system will work better, will work effectively. We have seen that our health system is quite unequal and it's so fragmented. So if we are to have different population being served by different schemes, will result in the inequality, inequality getting bigger.
Professor van der Heever, let me come back to you. Still on the issue of the public-private partnerships. Of course, one of the things that I had never seen was a situation where you had, in some instances, private hospitals in some parts of the country completely overwhelmed and having to divert their patients to public hospitals as well. Reflect on that a little bit for me, and do you think that the relationships that have been forged in working together during this period are what can form a foundation going forward for the NHI?
So firstly, and I want to be quite clear on this, the central thematic proposal of NHI, which is to have somebody in Pretoria buying health services around the country, is just not going to happen. And I think that some of the problems that we've seen in the collaboration between the public and private systems talks to this. It is not easy to harmonize the system structurally without creating some sort of coherent governance framework. That's a sort of very general statement. The reality was that large parts of the private sector waited around for government to get its act together. It didn't contract coherently, and it didn't actually work effectively with the private sector. The public sector was also very far behind in both tracking patients, managing COVID patients, and if we look now at the number, we take an example of Gauteng Department of Health. They effectively have recorded fewer COVID patients in the public sector than in the private sector in Gauteng. How is that possible? So either their systems are so weak that they can't actually track the COVID patients efficiently, or the patients didn't come. So there's a lot of issues about the gaps in the public sector that have been revealed that suggest huge governance weaknesses in the state systems. But the health market inquiry has pointed to a range of issues that need to be resolved in the private sector. These are complex issues, complex systems issues. And the problem is that we can't really talk about a future health system in oversimplistic terms. We have to have a universal coverage model that covers everybody, but it's not going to be a single payer scheme. It doesn't really matter how many times some politician says it, it's not going to happen. And we've also seen the corruption that has emanated from the National Department of Health and the Minister of Health potentially, in which, where in the NHI proposals, the Minister of Health would be appointing everybody into the so-called NHI agency. Those are problems with the design, which means that we can't really talk to the design that's on the table, and it's completely inappropriate for the South African health system. There's just so much wrong with the proposal. We need a revisioning of our institutional framework. And the COVID experience has just shown up the weaknesses in both systems.
All right. We're going to have to leave it there for tonight. Let me thank you both for your time.